why we are here today. Can you let me know when y'all can see my screen? Perfect. So I want to just take a moment to welcome you all to the space. And again, thank you for having me for this DIS Echo series. For today's session, we are going to be focusing on one of what I think is the most essential and oftentimes most challenging parts of the DIS work, and that is the navigation of the difficult conversations within partner services. So, our goal at the end of today is going to be to normalize the discomfort, but we're not just saying that. We're going to be demonstrating how to build confidence, how to strengthen communication skills that will also support client trust and engagement. So, as Stacy mentioned, I am Dr. Mariska Osborne-Wells. And yes, you can call me Dr. M, Mariska, whatever is more comfortable for you. And outside of what Stacy has shared with you, I have been a DIS. Just like some of you, I was a DIS for 15 years. And I left DIS, went into training and development, went into HIV surveillance. So I've done a little bit around public health for a while and loved it so much. I decided to invest in it and become a doctor of public health, which now seems too much, but I have fun with it either way. So, what are we going to be doing over our next 4 sessions together? Today is going to be normalizing the difficult conversations. And within that, we have several objectives that I'm going to lay out for you, but we're also going to walk through some interactive questions. I can talk a lot, but you all actually bring the content that we can unpack. We can have the conversations openly because I guarantee you, if you're having a difficult conversation, your colleagues are also having a difficult conversation. So, how can we use each other to navigate? You know what? I should have said this. Maybe I should have tried this different, or maybe I just was not in a mood to deal with the client today. So, how do we have those conversations with ourselves, our supervisors, and each other before we even go out to the client? The second session is going to be an introduction to the STI HIV interview format. Sometimes it helps to have a script, some type of concrete narrative that I can make my own. So just because I'm giving you all the language, it may not fit with your personality. Because as you can tell, I'm a little bit of an introvert, selective extrovert. I can turn anything into something that's going to feel comfortable for me to say, and that is what I want you all to be able to do. So, with the format, you'll get a script, you'll be able to practice your introduction and what that looks like, how it changes per client. Session 3 is going to be going through the stumbling blocks that I'm hearing that you all are having. So we are going to set up the role play scenarios that we are then going to use in session 4 for my favorite session, which is the role play. And I do not want y'all to start getting scared off because of role play. This is the mistake zone. So if you're going to mess something up, this is where you do it. You get the support of your colleagues and you get some insights. You know what? And y'all, I love to use people's names in things. So since I just met Kayla, I'm going to use Kayla as an example. If I'm going through my role play with Kayla, Kayla has some dynamic words that she's used or she set up the transition so well. I'm like, you know what? I might want to try what Kayla did, but make it my own. So just as you're going to learn some new skills, I want you all to be able to learn from each other as well. So I cannot see chat. So Stacy or Kayla or Desiree, would you all mind just stopping me if stuff starts popping in chat as we move along? Awesome. I saw a thumbs up. Okay. So normalizing difficult conversations in partner services. Here's our objectives for today. We're going to identify the purpose of partner services interview. Sometimes it helps to go back to ground zero. Why is it that we do what we do? What are the purpose? What is the purpose of it? Why is it important? We also want to identify some barriers that make these interviews more difficult. And I don't always like to use the word challenging because challenging just sets you up for failure already. Our clients are going to come with some hesitance. We want to figure out how do we approach that sensitive and difficult topic and still maintain that level of professionalism to get to the partner services piece. We want to elicit those partners and prevent the spread of disease. We have two roles, primary and secondary disease intervention, folks. That's it. We're not there to judge. We lead with curiosity and we help them navigate a system that is quite difficult sometimes. Next, we want to identify how the transparent, honest communication improves outcomes within our disease interventions. And lastly, I'm going to give y'all some grounding strategies that can help reduce discomfort in the interviewing process. So I would love for y'all to put a one in chat for me if these are all objectives that are going to meet your needs for today. So go ahead and put a one in chat if these are right up your alley where we are at. How are we looking?
We're looking good. We've got quite a few ones there.
Awesome. Okay. So my first question to you all, and I would love for you to put this in chat, or I also like to hear voices. Come off mute and talk with me. What do you all think is the purpose of partner services? What do you think your purpose is?
Got get partners and prevent the spread of disease.
Yeah, I love that. Yes, we want to get to those partners before they develop symptoms. If they've had an exposure, how do we get to talk to them? Awesome. Others. And again, if it's easier for y'all to come off mute, please feel free to do so. Stacy, they're gonna be a little bit nervous, but like
Yeah.
I love calling on people,
Yeah.
so we're gonna have some conversations, folks.
Can you see the participants?
Oh yes, I
Okay.
move them around to make sure I
Okay.
can see some names.
All right.
Hello, this is Patty, and I think to assist people with their sexual health.
That's Patty. Thank you so much. Assist them with their sexual health, because sex is a part of our natural being, right? We don't care how they're doing it. We want them to be safe and make it pleasurable and enjoyable, right? So, yes, we want to talk about their sexual health.
We've got work with partners to ensure resources are efficiently and effectively utilized to address public health. That's from Catherine Scott.
Yes, Catherine.
And Elizabeth Adams says for her group, it would be to help reduce the transmission of infectious diseases.
Absolutely. And you know what? Y'all have named almost everything on our list for today. Um, so partner services, why do we do what we do, right? These are the basic three. Identify and locate sexual or IDU partners who may have been exposed. So that is part of the primary and secondary reasons why we do what we do. We want to get those that are exhibiting symptoms tested positive and get to those before they start express or exhibiting symptoms of disease, right? So we want to get to those people that have been identified, give them the test and treat that they need, and arrest disease. Next, we want to notify the partners confidentially and offer that testing and counseling. And my favorite thing to do was the linkage to care. because you've given me something that I need to do my job. And now I want to give you something that helps you, as Patty said, have that healthy sexual lifestyle. Because now you get to navigate the services that we offer and make sure that you're going to be healthy in doing it. And lastly, providing the index client with the prevention counseling. You've got one infection. How do we keep you from coming back to our services? I know Montana has some great people on their staff, but sometimes you just don't want to see people in your office the same week every other month, right? So we want to get them the services that they need. The interview is also important because we're going to reduce ongoing transmission. I used to joke as a DIS, when people are having sex, it is job security because there's going to be somebody that tests positive for something, right? Because no one's having the conversations. They're all a little bit too scared. If I have a symptom, I don't know where to go. So, how do we navigate that for the folks that may have been exposed to someone that tested positive? A lot of our infections are asymptomatic. People are walking around with chlamydial infections that turn into pelvic inflammatory disease or some type of reproductive disruption because they don't have a clue what's happening inside their body. So we want to normalize that while we're having this conversation. Hey, guess what? We can have your partners come in. We can offer free and confidential testing. You allow me to notify them. You remain anonymous. So there's a lot of pluses in doing what we do. We also want to strengthen public health response by connecting them to the prevention tools, the treatment, any other support services, if it's mental health, if it's substance use disorder. Montana, when I was out there, I love y'all, but there's a lot of care deserts. There's a lot of food deserts. So how do we navigate services when they're not readily available? So that's part of what we do. And then lastly, we want to build trust and rapport with the clients. I'm old school. Word of mouth can ruin everything real quick in trust, right? So if we have a client that they didn't feel comfortable with us, what are they going to go do? They're going to go tell their partners, don't talk to this person, they can't be trusted, they lied, blah, blah, blah. Word of mouth is how we advance in our field. So I've done a lot of talking there. This is where you all come in again, and I would love to hear some voices. What are some of the reasons these conversations or interviews are difficult? What's showing up for you? Who are my people that are actively doing interviews? I would love to hear from you.
We've got age of patients. And Gretchen, do you
So
mean how young they are or
I
how
was going
old?
to say, Gretchen, come off mute and expand on that for me.
Yeah. One of the things is if you have like a teenager who they test positive and it's their, first time experience, and then they give you their partner and you have to tell another teenager. So it can be kind of difficult because, they're still young and this is kind of very new and they have to sort of navigate through it.
Oh my gosh, yes. Their prefrontal cortex is not quite developed. The amygdala is throwing a lot of emotional responses at them. So it's like, how do we even get to their level of talking to them to where they're going to either take it seriously or they're going to be action oriented, right? So thank you for bringing in the age. I think that's super important. On the other spectrum of that is our elderly, or sorry, I don't want to say elderly, our seasoned patients who are still engaging in sexual activity. They know it all. I don't want to hear some young whippersnapper tell me that I need to use a condom. I haven't used a condom in 50 years. So we do have that double-ended of spectrum. Others,
Got Patty Presser says we all have our own values.
I can assume, but Patty as well. Can you tell me a little bit more about what you mean by the values? I don't want to put words to what you're saying.
Well, we may have values that are different from our clients, but we're not there to judge. We're there to help them with their sexual health.
Absolutely. And we were on the same page, but I just didn't want to jump in there with the wrong words. But yes, we come with our own set of values, our own set of beliefs. You know, some of us may not be okay with promiscuity, but our clients are. We may not be okay with survival sex. Our clients might be. Our role is to introduce a safe, culturally responsive environment that is based on curiosity. Tell me your story. How did we get here? What can I do to help you make this a better experience, etc. So thank you for bringing in the values.
Mindy said interviewing a person of the opposite sex can be difficult sometimes.
Okay. Mindy, where are you? Would you mind also expanding on that? Or I'm going to put you on the spot for 1 second. When you say interviewing the opposite sex, what has that looked like for you if it has been your experience?
Well, sometimes the gentleman will ask awkward questions or go into detail or stuff that isn't really relevant to what we're trying to get through or trying to understand or educate on. So
Okay.
sometimes that can get awkward. Yeah, challenging.
So it's almost like they're trying to do the embarrassment and shock factor by making it more sexual than it needs to be.
Correct. Yes, that's exactly
Okay.
it.
I am with you. I want to make sure that we're calling these things out as is, because then we know where some of these issues lies. And yes, there are some people, and I will tell you, it's not just the gentlemen. I had several ladies that were in the business, I call it, of sex, and they wanted to test out my fortitude for what they do. I was like, cool, let's do this. I don't know that topic, so let's talk about it. But that's just me leading with curiosity, right? So, how to turn that uncomfortable situation into a learning and teaching moment. And it might also empower your client to be able to say, oh, well, she didn't know that, so I can tell her this. So, thank you, Mindy, for bringing that up.
We have language barriers.
Huge.
Mm-hmm.
What
And
are
then,
some of the languages spoken in Montana? What are y'all encountering?
and that's from Jan. And Jan, are you in Montana?
No, I'm not in Montana. I'm actually a DIS from Texas.
Oh, okay.
But I
Go
love
ahead,
coming to
Texas.
any DIS trainings I can find online. So, yeah.
Jan, welcome. We love Texas too. We will not be mad that y'all are at the other end with sunshine right now. I
Um,
think
we have a couple people who are saying small towns where everybody knows everyone, so they might not say much.
I remember when I was there for training, that came up a lot. And with not even that they don't say much, everyone knows everyone, but these are people that you may have grown up with that now you're interviewing and they don't trust you. They don't have that comfort because maybe you have the same group of friends. How do we navigate that? So small towns is very huge. I can work with that though. Anything else, Stacy?
Um, Elizabeth, I think Elizabeth, you work at the state and they provide ICARs, infection control. You'll have to, Liz, you're going to have to come off mute to say what that is because I can't think of it right now. But they do that for healthcare facilities, so they have to be understanding of challenges that are specific to them and be sensitive to that when presenting infection control gaps.
And where's Elizabeth? I don't know what IHARS is.
Yeah, I'm sorry. And my section is so broad with providing infection control resources and information, but ICAR is an infection control assessment and response. So it's an on-site assessment that we do for healthcare facilities. But
Okay.
I thought this training would be helpful for me because sometimes it's difficult to share with facilities the gaps that they have that they haven't really realized. And sometimes they can be pretty serious. So Um, anyway.
Not to worry, Elizabeth. Communication goes across all genres of profession. So everything that we're going to talk about, you're going to be able to amend it to what you will need for your language, okay? All right. So
That's it for now.
I'm sorry,
I said I got to the end
oh,
of the comments.
okay. Awesome. So a couple other things that make these conversations difficult. And y'all kind of alluded to a lot of these: fear, shame, stigma. We have a lot of uphill battles in those three things. What people hear about disease, it's always a dirty connotation that goes next to it. If you're having sex outside of marriage, oh my God, how dare you? There's still that level of fear and shame. We have a distrust of government. And right now, public health has been taking a hit. The science behind what we do has been taking a hit. So we have to create additional trust based off of what has been destroyed. We also have the cultural or linguistic barriers. And y'all mentioned um, age. The ageism gap is also difficult. The gender gap is difficult. Number one thing, confidentiality in a small town. Who's going to know that I'm even here talking to you? Who's going to know that I named them? Well, I only had sex with one person, so they're going to know it's me. But, they may have other partners as well. I don't want to just focus on what's happening in the conversation. It's also important to figure out what is the DIS or the provider experiencing. And this is not an exhaustive list, folks, but sometimes you have fear of saying or doing the wrong thing with the client because that one thing that you say collapses the entire interview. We have high burnouts. 24 months is still the lifespan of a DIS profession. There has been research studies done that burnout for DIS happens around that 24-month mark, and they are ready to leave the field. Some don't make it that long, and some stick it out for 10 plus years. I was one of those people, but I had a great support system. Then you have your personal discomfort. I don't want to ask people about the last menstrual period. I don't want to ask people how many partners they've had. How do they think they've gotten this infection? There's a lot of questions that when I first started, I did not want to ask people. But today, after training and support, I can talk to anyone about anything in their life, right? And then lastly, they may have that organizational pressure to perform. Partner index has to be at a certain number. You got to close those cases in 0 to 3, 0 to 4, 0 to 7. There's a lot of pressures to perform, right? So I'm going to ask you all another question based off of what we just talked about. And this is your moment to bring to the forefront what's happening for you all. I want you to think of a recent moment when you felt that tension rising within and just jot down a sentence. What happened in that situation? And now that you've been stepped away from the situation, I want you to think of an alternate to that sentence. What would it sound like now that you're like, I'm out of the moment and my brain is working, I have time to process it. Write a different sentence to attach to that scenario. Are you able to think now that the moment is gone? Your emotional regulation is back. Has it changed or is it kind of still, I'm still stuck. I wouldn't know what to do in that situation. And what does that sound like? This is your moment, folks.
While they're thinking of that, and if you want to come off mute or put it in the chat, it made me think of, since we were talking about teenagers, when a parent answers the phone
Ooh.
and how you feel and you get kind of panicky because you're not going to talk to the parent, but they're like, I know it's about this and I know that they went to the doctor and you need to tell me I'm their
Right.
parent, like that feeling.
Oh, I used to hate when parents answered the phone. And then it's like, so I will, Desiree, I'm glad, or Stacy, I'm glad you brought that one up because it used to be one of my favorite scenarios. And I told DIS in training, I've had so many kids. Y'all, I don't have any kids. But when it comes to dealing with another parent, I attach to their emotional need. And I'm like, you know what? I totally understand because as a parent, I would have the same level of concern. But as a parent, what I can do is encourage your child to have a conversation with you after I've had a chance to talk with them. Parents are usually okay with that. But I probably have like 20 kids after talking to some of these parents. What do y'all got? This is your session. Y'all are so quiet. Maria, I saw you come off mute. Talk to me. Uh-oh. Maria, did I lose you?
I think she might be trying, but we can't hear you, Maria. Type into the chat if you're trying to talk.
Yes, please. I would love to hear it.
Elizabeth said sometimes it helps to ask what their concerns are first. And Maria did say, I'm trying.
Okay.
Can you not hear me? We can't hear you, Maria.
Yes, I'm going to address that, asking about the concerns. Tell me, what are you most concerned about? And I love asking that question. But also on the flip, don't belabor it. If they say, you know what, I don't have any concerns, I just don't want to talk to you. I can work with that. How much time can you give me to chat with me right now? I think I saw Patty come off mute as well. I don't want to call you if you didn't.
Hi, I'm very talkative today. I
That is
was in a
okay.
I was in a situation the other day where I needed more information because of incubation periods and different things so I could make decisions of what to recommend and what to do for the patient. And I needed really, really a lot of specific information, and I felt uncomfortable asking for that much and going into that. So, but now that it's over, I just realized that I really need to make that clear to the person and tell them that I need why I need the information and then just ask it.
I think that's absolutely valid and it happens a lot. So if y'all are not familiar with the re-interview, I love a re-interview. Patty, we need a lot of information in a short amount of time. So how do we prioritize what is immediate to attach to that incubation period or the interview period, whichever one I'm working with? And you know what? Right now, I can't think of another thing, but I know I'm missing something. Would it be okay if we followed up on 2 days from now or 3 days and just keep that conversation going? And that's how we're going to build that rapport, folks. We don't want to feel like I need to ask a million and one questions in 15 minutes. It's about the prioritization, assessing where the client's at, and really making sure I have a way to contact them again. So I appreciate you bringing that into the situations because it's huge, right? How do we navigate the priorities?
I feel like I should just finish with that every time, even if I've gotten everything I think I need. Just say, there's going to be something I've forgotten. I think,
Hmm.
and you might think of some more questions. So that's a great idea. We do have Melanie said, tell me more.
Melanie, you're reaching over my shoulder. I love Tell Me More, as y'all I've demonstrated to y'all. Tell me more about this. Unpack that for me.
That was my favorite part of the training that we had. I use it all the time now.
Nice.
That tickles me. I high five to me. Yay. Okay, so because we're short on time and we have a lot to talk about, y'all look in chat, give each other some thumbs up if there's something that you feel that, oh, you know what, I've had this situation. Support your colleague, give them some love, okay? We want to talk about some reset strategies. When you're feeling in that moment and y'all have described, oh my God, Patty, I need to ask all these questions and I'm starting to panic because I'm running out of time. How do I re-regulate, get myself together, excuse me, I want to give y'all four things that you can potentially do, right? So the first is pause, breathe, and then respond. That is just a 3-second reset before you speak. Because sometimes we're in that mode when we're listening to respond and wish the person would shut up so I can tell you what I want to say because I can solve your problems in 5 seconds. I don't want y'all to do that. Take a breath. Whew. Okay. Now I can respond. Having that neutral tone and slowing your pace. This also helps us to regulate that emotional response that we're having. Our temperature may go up, heart rate's going to go up, but you're going to actually take a pause. I can respond in that neutral tone, and I'm going to slow my pace purposely. We also want to name our intention. My goal is to support you, and I want to be transparent with you what I need from you. We're working on X, Y, and Z. My goal is to get you tested and treated, as well as your partners who may have been impacted by this infection. And then lastly, the boundary phrases they're just calm, non-defensive. If things are like going super maddening, use that pause and breathe. I want to slow things down so I can understand what you need in this moment. Or I want to make sure we're on the same page. And this is where you can use that re-summarizing and just listing out what you have heard from the client already. While I say all of that, y'all keep in mind that this is just a conversation. If it starts feeling confrontational, we want to go back to leading with curiosity. Pause in that moment. I'm sensing things are getting a little bit chaotic right now based off of some of the things that you're saying to me. Let's take a moment and start unpacking some things. Tell me, what are your concerns? And we can always assess concerns as we're talking to that person. So how do we manage all of this? First, we want to build rapport and establish trust. And I was told that I can send slides to you all. So if you're note taking, put down the pen, you'll get all the slides. All right. So building rapport is fragile, to say the least. We want to be able to use that active listening. We are often meeting people at their most vulnerable moment after a new diagnosis, or they've been notified that they have had an exposure. So imagine the complex set of emotions that are running through them right now. They may not even know where to start in the conversation. So, long story short, it means your role isn't just providing clinical information, disease information. You may have to be that social support for the client in the moment. Their trauma responses are triggered. And sometimes I don't like to use that word when it comes to other people, but it's what's happening. We've given them some news, or they've received some news that is life altering and confusing. So we want to be able to engage that patient with care, patience, and intention. And I'm going to use the trauma responsive care or trauma informed engagement. And I think some of you may have heard this in trainings before, but being trauma informed starts with understanding that trauma affects how people perceive safety, control, and trust. So the most powerful tool we have is building rapport, identifying with where they're at and being patient, operating in no judgment. And this can look truly simple. Introducing yourself clearly and explaining your role, asking for consent before moving forward in the conversation, making sure your body language is open, inviting, and non-threatening. And we also want to build trust when we follow through on what we say we're going to do. If we don't have it within our purview to deliver something for this client, let's not promise it. If you're not familiar with motivational interviewing is a technique that is essential to help shifting from telling the person what they need versus exploring what they need. So we want to be explorers in that person's life, not pushy. We're going to ask the open-ended questions using affirmations. And I have a couple more slides that I'll share what motivational interviewing looks like, just to give you the foundation. We're not going to dwell on it, but it's going to give you some homework to do. Next, we want to respond with empathy and compassion. Our interactions with the clients are going to go way beyond data collection and medical follow-up. We're sometimes invited to that client's life with a balcony view during their moments of high stress. So, how do we honor that invite and prevent triggering a trauma response that can be emotionally crippling for some of our folks? Okay. So, responding with that empathy and compassion, what that may look like. We also want to support autonomy and self-efficacy. It is what the client is ready to do for change. They make their own decisions and they want to believe in their capacity. But we're also doing some of this for ourselves because we need to know what choices are available, right? And that's part of that normalizing the difficult. And I want to pack my toolbox with as much information as I can to be able to navigate all of these different scenarios without doubting my skill. And I hope that makes sense. Okay. And then we want to address the high stress environment, being sensitive, because y'all, we're just coming at these people out of the blue sometimes. They had no idea. They love their partner. They've been married for 15 years. How could they? And this is wrong. And someone gave you my name in jest, and somebody's playing the game. There's a lot of triggers that include the fear, the anxiety. And this in turn creates a defensiveness and a hesitance for them to work with us. So, how do we maintain a trauma-informed approach? And again, I can't stress this enough. Trauma-informed is not just for our clients, it is for you as well. If you feel as though interviewing this person is going to create that trauma response for you, with secondary trauma, this is where you want to pull your supervisors in or your team lead. Have that conversation. I don't know how to do this. I don't know if I can approach this person with this empathy that you want me to. There's a lot that happens, folks, and that is part of assessing yourself. Can I even have this conversation? That's normalizing it. If I can identify the discomfort that I'm feeling with the conversation, how can I navigate through it by talking with someone and preventing my own trauma response? Does that make sense? Anything in chat, Stacy? I'm going to pause there for a second because I feel like I've been yammering.
Well, so Maria, for whatever reason, we cannot hear her sound, but she had a really great situation where she was trying to reach, I'm assuming it was a young man, it might have been a teenager, I'm not sure, but she got an aunt, and then that aunt gave her another number, and she did not share any reason why she was calling other than to say, I'm a public health nurse from Lame Deer. And once she did get a hold of him or he called her back, he was very upset and it felt like she was harassing his family and talking about his private information. And she said she was sorry. You know, she used the number on file and it led her to somebody and to the next person. And then she said, I'm just trying to speak with you. And she told him why she was calling. He was still annoyed, but she remained calm and discussed treatment options. And by the end, he was way more calm and thanked him for calling. And she let him know everything was confidential, that she cares about his health. And that's why she reached out to him. So it sounds like Maria really had, yeah, a great response in a difficult situation, a young man. Thanks, Maria.
Oh my God, Maria, absolute applause.
And he cussed
Because
at her a couple times.
Oh, I was going to say, I'm sure he was not entertained by your voice. But I think those situations come up more than we realize. And Maria, you mentioned staying calm. You led with intention. I tried this number and they actually cared about you. I care about you. I care about your health because, in a way, we do. These are people that live, work, and play in our community, and we want our community to have an overall health, right? So I think that is a perfect response, Maria. Kudos to you again. And I hope you're getting some love for that because that ain't easy to navigate, not just the aunt, but then the angry young man who's using very colorful language. And we don't want to match energy with energy, y'all. We want to rise above it and build rapport. Great
Yeah.
work.
And Maria works in an area where anybody she calls might know who she is and where you live and where you work,
Mhm.
and she's going to see them. So
Oh,
that's,
jeez.
yeah. So takes a lot of courage.
Okay, so we might need to start identifying these folks that could be great assets in our skill building as we move forward in role play. Just putting that out there. All right. MI might be new to some of you, but it is a fabulous new communication tool. I like to think of MI as patient driven because the things that we want to accomplish require a collaborative approach that is the practitioner patient relationship, DIS, client relationship. It is going to be patient centered. And that includes being reflective of what the patient needs in the moment, their feelings, their perceptions, their responses. And we're going to be looking at some of the affirmations that need to happen. So this is not a full MI course. This is just an overview. In that, I want to share the spirit of MI. It focuses on that competency and strength. It's going to be individualized, client-centered, and develops a partnership. What that partnership looks like, again, is driven by the client. We're going to use empathy, not authority. So the tenets of MI, collaboration, evocation, and autonomy. What do I mean when I say collaboration? Cannot stress. It's partnering rather than persuading. So you are now partners with that client, and we want to build that relationship. Where does the client want to go with their interview? What do they want to get out of it? Um, with the evocation, we want that to be eliciting change from the client. So if there's a behavior that you're in your mind is like, oh my God, this is putting this person at exponential risk to get another STI, but I can't say it in that way to the client. Some of you are already leading with curiosity. Tell me how you think you got this infection. What did that look like for you? Who are you most concerned about? But rather than us imparting it, we're going to ask those open-ended questions and the tell me more. Tell me more about what you know about this infection that you were diagnosed with. And then lastly, the autonomy. If they say, you know what, I don't want your services. Okay, cool. But here's what I can do for you. I'm going to leave that door open. Here's my information. They are going to be in control of the decisions that they make, but I'm still going to be in the background. If you need condoms, if you need testing, please call me. It's free and confidential, but I'm going to keep planting those seeds to keep contact with them as we move forward. And I talked about open-ended questions. And in DI world, y'all, we love acronyms. So OARS, easy to remember. We're asking open-ended questions to get to know more and unpack. And I like OARS because it disarms the difficulty of the conversation. If I have a script of open-ended questions going into the interview, I can make those my own. I don't have to ask them robotically one by one by one. Based on what the client is telling me, I can throw in another open-ended question to keep them talking. But I also want to be able to affirm the positive. Put yourself in that client situation. Do we respond better to negativity or do we respond better to positive? And Desiree, my darling, I'm going to use you for a second. When Desiree came on camera, I noticed she had a whole new hair color. I'm like, yes, ma'am, that hair color is rocking. You're doing your share thing. And the energy that she displayed after that affirmation was so interesting. But just something as, hey, you know what? If you have someone with substance use disorder, if they had made it 40 days out of 45 of sobriety, celebrate that. We want to affirm the positives. That's all that means. And then we want to reflect. And this looks different for a lot of people. So providing reflections. This also ties into summary. What I'm hearing you say is, and then they have a way. When you said this, you said you want to be more safe with condom use, but you're also meeting folks on bareback real time. We know bareback real time, folks are looking for raw sex. Help me understand that a little bit. And that's all that ORS is, nutshell. What questions do you all have on MI so far before we go through change talk? Because I want to do one activity before we part today.
Not seeing anything in the chat yet.
Okay, y'all interrupt me at any point. So eliciting change talk using the ORS. We already talked through this a little bit. Elicit more information, questions that you want to ask of the client. This is where we unpack and use that tell me more, that polite imperative. Describe for me and use your who, what, when, where. Do not shy away from why, just as long as it's not a judgmental why. I'll give you an example. I had a client who didn't want to tell me their partner because the partner would get upset, they would leave them, and I actually used why. Tell me why you're putting this person's needs ahead of your own. Why are they more important than you? So there is a way to use why when we're using the open-ended questions. Shining the light on their strengths and efforts, the reflections, helping the client feel heard, taking that conversation deeper. What I'm hearing you say is, and then when we summarize, we talked about a lot today. Here are some of the things that you've shared with me. Here's some of the things that you want to work on. Here's how I can support you. Who else can support you in making your changes? And I'm going to bring this back to the normalizing of the conversation, right? When you all are struggling, how do you talk to your supervisors or your team leads about where that difficult conversation is coming up? This is something that you can also use to unpack where my discomfort lies in conversation with my supervisor or my team lead before I go out into the world and talk to the client. Does that kind of put it all together how we can also use the same tools with the client as with ourselves? Or did I lose some folks? Go ahead and put a 2 in chat for me if this is coming together and something that you can use for yourself. Because we're going to put it into practice.
We got a 1.5
I love a 1.5. That leaves
Yeah.
room for growth.
and some 2s.
Okay.
2 with intention and practice.
I love it. And I see some leadership in the room, so your leadership is going to get the same information and they are going to be ready to support you. Okay, so let's do a case study, friends. And I love Carla. Carla has been around for a while. So I'm going to read this out loud for those of you that like to read along. Carla is a client of yours and is currently experiencing unstable housing. Carla has been diagnosed with Hep C. During your conversation, she shares that she is worried about giving others hepatitis C and is fearful of getting HIV. Carla also mentions that she is living in an encampment with friends and people she considers family. Her biological family is of no support to her and has shunned her. Carla tells you that she often shares needles with others in the encampment and occasionally uses condoms. Later, she says she doesn't want to stop injecting drugs with her friends and doesn't want to know her HIV status. So Carla's had a little bit of a change of mind, right? So I would love to hear from y'all. We're down to 5 minutes, so come off mute, put it in chat. What are some open-ended questions that you could ask Carla? And even if they are the difficult questions that you're like, yeah, I'm not sure I'm comfortable with this, pop that in chat or come off mute and share that with me. I'm going to pick on someone I haven't heard a voice from yet. TJ, can you hear me?
I can hear you.
Fire off an open-ended question for me, friend. What would you want to know?
I don't know if I have an open-ended question, but I do have a comment about one of the uh, things you mentioned about, tell me more about why you're using this website. Help me understand. I listened to you say that, and I thought to myself, and I'm like, if I was a patient, I would be like, why do you need to understand why I'm using it? What is it that you need to understand? I would feel very attacked by that statement. And so I wonder why you chose to use that. Like, you don't need to understand why I'm using this. I'm using this website.
No, no, no.
So
So,
what would be your
yes, thank
workaround
you
when
for bringing
somebody
that up.
said
Let
that
me
to you?
clarify. Um, so there is a way to ask the question. If they're saying, I use condoms 90% of the time, and this is where that knowledge comes in. If they say, I use BBRT for my hookups, okay, I'm not putting the two together. You're telling me that you're using condoms 90% of the time, but meeting partners on here. How do you navigate those two things? And it's more of a curiosity from I want to be able to offer you prevention messaging, but then the behavior and the risk are not aligning. So I don't want to give you the wrong information or steer you in a way that is going to mess up your jive, because that is not what I want to do. If you enjoy raw sex, cool. Let's talk about a different prevention message, such as having the open conversations with your partners. Does that make sense? So it's not a judgment. It is,
No, that definitely makes sense the way you just put it, but the way you said it earlier, if I was your patient, I would take it like, why do you need to understand why
oh
I'm
no, absolute. Call me on that.
yeah.
I can definitely explain. I appreciate the call out. Actually, I don't call it a call out, a call in. Others, if anything stands out to y'all, please. TJ demoed how we do this. Let's have the conversation. Or what came up in chat, Stacey? I keep
Yeah.
forgetting about chat because I can't see it.
That's okay. Liz asked or said she would want to know if she has access to clean needles, and she would ask her if she would like help to learn more about hepatitis C.
Okay, I like it. And is access to clean needles something that can happen in Montana for you all?
In some places.
Okay. So knowing where that resource is available and how to help clients navigate it. I like it. Okay.
That's all we've got. Oh, here we go. Know if she's interested in helping her family, so the people in the encampment understand that she wants to make sure they do not get Hep C.
Awesome. Potential for outreach, and without having Carla be the conduit for sharing the encampment information, we can just go to the area with outreach information. Or let me back up. Is outreach available in your jurisdiction? If not, don't create work where it isn't. If outreach is something that you all have, how to partner with the outreach folks and share that information that, hey, this might be a good place to go. Okay. Hearing nothing else and seeing nothing else, let's talk about some of our key takeaways. So number one, difficult conversations are the expectation. If it doesn't happen and you're not feeling it, don't belabor it. If it's not difficult, do what you normally do. But if difficult conversations come up and be like, okay, you know what? Let me pause, breathe, and respond. You always have a purpose for why you're doing what you're doing. So it's not that we're being nosy, we're not being judgmental. We are leading with curiosity for one, community health, healthy sexual encounters that folks are going to have with their partners moving forward. And we want to identify strategies to keep the conversation moving using MI. And then we want to practice with our colleagues to become more comfortable. As I said, you have your leadership in the room. You have other colleagues that are, as I think it was Jan is in Texas. We can do cross jurisdictional conversations. And then lastly, we want to identify where the hesitance is coming from. Is this part of our belief system, or is it just the client's hesitance in talking to us that we have to navigate? So identifying where the hesitance lies is part of that conversation. What questions, what concerns or comments do you all have before we wrap up? And I think I'm 1 minute over. My apologies for taking your time.
Maria said all of this is so helpful because she is the loudest shy person you will ever meet.
I love a shy person
Yeah.
because y'all are so observant and you see things that me as an extrovert I do not see.
Yeah.
All right. And Stacy, you have evaluation link, I think.
Yeah, I think Desiree put it in there. Desiree, if you want to pop it in there one more time. And then I'll let everybody know that we are meeting again in 2 weeks. That's on March 26th. That is again with Dr. Osborne-Wells. And if you know someone who you think can benefit from this ECHO program, you can forward them the information to register. And we will get them all set up. That topic will be I've
The
changed my
STI HIV interview
Thank you.
format.
Thank you. I changed my screen and I'm only on one screen here. So there we
I
go. And
got you.
this is a registration link. If people want to share that with any of your colleagues, they can join at any time. So thank you for coming today.
So, thanks for having me. And I can stay on a few minutes if folks have questions they didn't want to ask out.